Hello, everyone. This is Habib Srour, one of the attendings with anesthesiology critical care here at UK. I'm going to be talking a little bit about emergency surgical airways. I'm going to go ahead and give a shout out to Dr. Hatton. I used his previous podcast as a template for this one. Some goals and objectives. We're going to talk about emergency airway options. That includes percutaneous cricothyrotomy and percutaneous dilational tracheostomy. So to begin, why are we even talking about this? So hopefully you have seen at some point the difficult airway algorithm from the ASA. There are lots of algorithms like this, but you can look at it and study it at some point if you haven't. But one of the important points here is that when you get to kind of the point of nothing else is working, you're going to go towards the invasive airway access option or emergency invasive airway access here. So you can see what that includes. Surgical or percutaneous tracheostomy or cricothyrotomy. So why? They're the only techniques available when ventilation inadequacy persists during intubation. Intubation is unsuccessful and emergency non-invasive ventilation has failed. It can be truly life-saving when other techniques have failed. It's actually, it comes up in the lay media. There are various TV shows where people use a pen to try to get, into a patient's cric. But some of the options for emergency surgical airways, there's a surgical cricothyrotomy and a surgical tracheostomy. So those are the two surgical options there. And then there's a percutaneous version of each of those, cricothyrotomy and a dilational tracheostomy. What's the best? So most authors argue that a cricothyrotomy is the procedure of choice during emergencies. There's debate about whether you should go percutaneous or open, and we'll look at the two different options. Emergency tracheostomy is associated with a higher rate of complication when you compare it to cric. So that's one of the reasons why authors argue for the use of cric. Tracheostomy downsides, the trachea is deeper. The tracheostomy site is also associated with a greater abundance of adjacent vascular structures. And if you've taken care of any patients in the ICU who have a fresh trach, bleeding is not an uncommon consequence of that. The trachea lies in closer proximity to the thyroid gland, sorry for the misspelling there, and the lungs. So both of those things are at risk. And the tracheal posterior wall lacks the circumferential cartilage ring, which is a big deal. If you've watched a tracheostomy, you can see there's a whole lot of pushing and shoving with the dilator. And when there's nothing rigid behind it, you get a higher potential for esophageal puncture and perforation. So in terms of the anatomical considerations, the laryngeal structural anatomy is important to know if you're going to be doing any of this. We'll look at that in a second. The thyroid cartilage is the most prominent structures as far as the surface anatomy. So when you go to feel a patient's neck, in lay terms, the Adam's apple, is the prominence there, the thyroid cartilage. It's pretty obvious on most patients. Obviously, there are variations. And then the vocal folds themselves are attached to the interior and anterior surface of the thyroid cartilage, approximately a centimeter above the cricothyroid membrane. So you can, feel that on yourself. Think about where the vocal folds are relative to where you're going to be working if you're doing either of these procedures. Here's a picture of the anatomy from the outside. So note that you have the thyroid cartilage here, the cricothyroid membrane, which extends here, and the cricoid cartilage. So the membrane area here, the cricothyroidotomy is going to be, cricothyrotomy, I should say, is going to happen right here. And there's probably a little bit of British spin on this particular picture. Note also that the blood supply of the larynx includes various branches that you should probably have in your head. The superior thyroid, the superior laryngeal, and the cricothyroid arteries, which aren't shown on this particular picture. But you can see down here also where the standard tracheostomy site lands and the difference between the two. So when talking about an open cricothyrotomy, you can think of a little bit about the equipment that's used. So you'll have an 11 blade, that's the sharp blade here. You can see on the picture on the left, a tracheal hook, an Armand Trousseau dilator. And you can see what that looks like here. They're kind of reverse clamps. And then 6 millimeter cuffed ET tube or 6 millimeter cuffed tracheotomy tube. And here's an example of either of those. In terms of the procedure, there's a lot of words here. I'll kind of read through them. And it's not something that you need to memorize just from looking at this, but it's something that you should have an idea of. And if you're going to be performing this procedure, obviously we'll need to memorize it and have some idea of how to proceed. So you start by creating a vertical midline incision through the skin, and it kind of goes from the point of the thyroid cartilage to the lower margin of the cricoid cartilage, and you can feel that on yourself. So it's a 4 centimeter roughly vertical incision, and then you create a 2 centimeter transverse incision in the actual cricothyroid membrane at the superior border of the cricoid cartilage. So you make that in the first incision through the skin, you get down deep and cut transversely across that. So you're making essentially a cross. And then you insert the tracheal hook and retract the tissues towards the head. So the hook will come in from above and retract cephalad. And then you'll insert the trousseau dilator with the tips closed into that opening and dilate in a head to toe fashion once that dilator is inserted. And then you will insert the ET tube or the tracheotomy tube through the dilated opening with that dilator still spread open. Once that's in, you'll inflate the cuff, ensure the proper tube position before removing the hook and the dilator. So that would be, using listening and using capnography, etc. Here's a picture of the percutaneous version of the cricothyrotomy. So this is a little bit different than the open version. So, and this is potentially the simplest, quickest thing to try to do in an emergency. Basically, you have a scalpel blade, a syringe, an 18 gauge catheter, over needle, a guide wire, and then a dilator that goes within a cuffed catheter. So there are lots of kits. They vary a little bit between the different ones, but roughly they're going to be something like this. Process for the perc cric. You're going to insert this 18 gauge needle with a fluid filled syringe. So just like when you're aspirating from any airspace, you'll put fluid in the syringe. You go in the inferior portion of the cricothyroid membrane. So what you felt before on yourself or otherwise, just above the cricoid cartilage. You'll advance the needle slowly and slightly caudad, which makes sense. If you think about which way the tube is going to be going, you want the needle and the wire ultimately to be pointing down towards the carina. You're going to have continuous aspiration until you get air. Once you get air, advance the catheter, remove the needle. You're going to insert a guide wire through the catheter. Obviously, you need to think about how far you put this wire, make sure that it's in far enough, you maintain control of it, you don't cause a pneumo by hubbing the thing. And then you're going to remove the catheter that was on there, leaving the guide wire, make an incision along the guide wire. Usually what's advocated is a horizontal cut, and that you need to make sure that that goes through the skin and through the cricothyroid membrane. So you essentially bury the scalpel blade. If you've spent any time in the cardiac ORs, or if you've done MAC introducers at this stage, placing central lines like the MAC introducer, it's very similar. You need to make sure that the scalpel is buried so that there's not a lot of fibrous tissue that you're still having to tear through when you're doing this. And you're going to have the dilator loaded into the airway catheter, just like the dilator is loaded into the MAC introducer when you place that central line. So you'll advance that combination over the wire into the trachea, remove the dilator and the wire, confirm placement, and secure with sutures. Moving on to the perc trach, some of the major differences from the cric. So where it's performed, obviously there's a tracheostomy, and so you can see, first to second or third to fourth rings, and we saw the picture earlier of some of the standards. The lower rings seem to reduce complications, and you can take a look at some images of tracheal anatomy to see why the thyroid kind of lays on top of it, some of the vasculature. Tissues get dilated separately from the placement of the appliance. So you don't have a dilator that is slid into the catheter like we just talked about, where it looks like a MAC introducer. And the tube is generally larger, so you get less airway resistance ultimately. Here's an image that shows a little bit of that structure. You can probably find better images, but there's lots of significant vascularity. There's the thyroid gland itself. A lot of things that are all up in your business when it comes to a tracheostomy, which is a little bit different than a cric. So in terms of percutaneous tracheostomy, the procedure is fairly similar except for the location. You make a vertical midline incision about 2 finger breadths above the sternal notch. You insert an 18-gauge needle with a fluid-filled syringe between the tracheal rings. Bear in mind that with the because this is a separate dilation, you make an incision in the skin, even though it's considered a percutaneous, and then you do the 18-gauge needle here. You advance in a slightly caught-out angle, continuously aspirating. If you've done any tracheostomies in the ICU or in the OR, a lot of times this is done with bronchoscopy at the same time if the patient is already intubated. So you look with someone's looking with a bronchoscope to try to find the needle as it comes through. Once you get air back, you advance the catheter into the trachea, insert a guide wire, remove the catheter, leaving the wire, and then you pass the blue rhino dilator over the wire and into the trachea. So this is what the blue rhino looks like. If you've seen any trachs, you will undoubtedly remember this thing. It has kind of a little piece that goes through the center of it that it sticks to the wire, is about the same size there, so that it bridges the gap, and then you pop it through here, and then change the angle so that it goes in the correct orientation with the trachea. So once that dilator the dilation is complete, you remove it, advance the tracheostomy tube into the trachea, inflate the balloon, confirm that it's intratracheal, connect the vent and suture. The technique can be modified in various ways. Usually that means increasing the invasiveness to try to decrease the complication rate. There are several kits that you can use in different sizes. As we talked about, bronchoscopy can be used if the patient's already intubated, but here we're talking about emergencies, so that would not be terribly useful. So as an example, just to give an example of what this looks like, this is not necessarily the perfect way to do it, but just to show someone going through it and kind of describing what they're doing with the mannequin here. So this is for a cric, and they are not using a catheter over the needle technique here, but they entered, aspirated air into that water, the fluid-filled syringe, and they're passing the wire through just the 18-gauge needle, not an angiocath. So that is one modification to an emergency cric. You can see they removed the needle, have the wire in there. They're making the incision with the 11 blade. The intention, I believe they made theirs vertically. I would suggest a horizontal. And then here's the dilator within the appliance. And so they removed the wire and the dilator, inflated the balloon, and are ventilating the patient. So they have the whatever the ties they're going to be using / suturing, or however you're going to secure the thing. So some additional considerations there. With a cricothyrotomy, it's associated with an increased rate of subglottic tracheal stenosis compared to a trach. So generally a cric, if it occurs, it's not kind of an end. It's just a bridge until it can be revised to a trach. There can be acute or chronic, in the case of acute or chronic perilaryngeal or neck pathology, you're going to have a lot more complication rate, which makes sense. And there are more complications in emergency versus elective cases, and it's fairly significant, up to 40% in some studies. Some of the major complications: unsuccessful tube placement, uncontrolled or significant hemorrhage, fracture of any of these rings or cartilages, as you saw with the video we just saw, and if you've seen any of the perc trachs, there's a good amount of force that's being applied here. Placement of the tube through the thyrohyoid membrane is also possible. And this is unfortunate because it's a supraglottic membrane here. So identifying things appropriately is obviously very important. And you can use ultrasound in that case to try to identify the appropriate locations. So some conclusions. Emergency surgical airways, they may be necessary in a cannot ventilate, cannot intubate scenario. Understanding the anatomy of the laryngeal structures might improve the outcomes during the placement. And you can use open or percutaneous cric or trach. They're all options. And obviously, in the case of an unanticipated problem, whatever kit is available to you may help determine what decision you're going to make. So hopefully that was helpful. If you guys have any questions, feel free to get in touch with me and have a great day.